Final seminar for 2025. Can't believe we're here already. For those of you who don't know me, my name is Jenna. I'm an AMS pharmacist here at NCAS, and I'll be the host of today's session. I'd firstly just like to begin by acknowledging the traditional owners on the land of which we meet today, and like to pay my respects to elders past and present. Today's session is going to be focusing on optimizing digital AMS, with two speakers sharing their insights in how technology can help to support AMS. The session will be recorded and will be made available on the NCAS website after the session. If you do have any questions, please put them in the Q&A chat box at the bottom of your screen, or alternatively, you can raise your hand and we can unmute you to speak. There will be some time for questions and discussions after each of our speakers today. So our first speaker is Ngan-Ha Truong. Ngan-Ha is a pharmacist here at RMH and NCAS, and she has an interest in digital health and currently supports hospitals to expand and manage their AMS programs through the Guidance Clinical Decision Support platform. Ngan-Ha works with clinicians and technical teams to develop digital tools and to optimize antimicrobial prescribing, auditing, and feedback. Thank you, Ngan-Ha. I'll hand over to you.
Thanks very much, Jenna. It's a pleasure to be here today. Let me just share my screen. Just move that over. Here we go. So today, okay, great. Today I'm going to talk about AMS tools in the modern healthcare environment. A lot of my talk will have a hospital focus, however, many points can be transferred to other areas. In the last 5 or 10 years, we've seen huge advancements in technology in healthcare. The rise in telemedicine has enabled service accessibility for a larger number of patients, particularly in rural regional areas. Many hospitals have undergone digital transformation or are in the process of implementing EMRs. Wearables with remote monitoring and mobile apps now invite patients to be more active participants in their healthcare. And the sharp rise in use of AI in many areas of healthcare, including note-taking, appointment scheduling and report writing, has already started. And there is emerging utility in areas like diagnostics. So this is Neurobot. He or she is an AI nursing robot introduced in Taiwan earlier this year. Neurobot assists with basic nursing tasks delivering specimen samples to labs, guiding patients around the wards and monitoring vital signs. So this signals a rise in healthcare automation. So there are many challenges that come with modern digital environments. So I'd like to point out some of the key ones that we address in our team. So a huge amount of data is being accumulated, and the challenge is how to manage and make use of this is a real challenge. There's been recent talk about physician burnout and increased pajama time for clinicians who spend more hours than they'd like to doing admin tasks, often at home, to meet the demands of EMRs. And that potentially can also apply to other clinical staff too. There is a huge amount of research output in the order of thousands of publications per year. And to keep on top of that is quite difficult. As an example, the therapeutic guidelines was previously updated every 3 to 5 years, and they had to move to an online version because the book got too big. So the guidelines are now being released regularly, which is fantastic. However, that's a huge amount of information, and there needs to be ways to help particularly our junior medical prescribers keep up to date with all of the changes and recommendations. So to address some of these challenges, we need tools such as clinical decision support systems and automated reporting, among a few others. So I wanted to first start by talking about the clinical decision support systems, or CDSSs, because while they've been around for over 50 years, they've evolved over time to be much more usable and meet the needs of modern technology, and still have a huge role to play in modern healthcare delivery, and particularly in AMS. So what are they? They're essentially digital tools that support clinicians to make decisions at the point of care. And they're categorised in a number of different ways. So we can have prospective or retrospective types of clinical decision support systems, and we see more prospective CDSSs in healthcare, and they can be active or passive depending on how much user input is required. So active CDSSs include alerts and reminders, while passive ones respond to physician input or patient-specific information. Knowledge-based systems provide recommendations from content libraries, while non-knowledge-based systems use machine learning and other statistical pattern recognition approaches, such as a clinical risk assessment or diagnosis. So in the diagram, we've got a knowledge-based system, which is essentially divided into three main parts, starting with the knowledge component. And combined with patient data, it forms sort of the beginning part, and then there is the inference engine or the reason mechanism containing formulas for combining the rules. And usually these rules operate on an if and then basis. So for example, if a person or a patient has had a previous recent MRSA infection, then consider vancomycin in the antimicrobial regimen. And the last component is the communication mechanism, where output may come in the form of a recommendation or an alert at the time of order entry, or even in other systems, even emails after the fact. So clinical decision support systems can take many forms. They can provide prompts, alerts and reminders, or they can provide recommendations, and they can be delivered via mobile apps, software installed on the cloud, or hospital IT environments or websites. And for EMRs, they can be order sets. Some examples of clinical decision support systems that we're aware of. This one provides prompting when for IV to oral switch for an antimicrobial that is prescribed that is highly bioavailable. This one is a sepsis order set, which originates from a sepsis flag that comes as an alert based on various conditions. So you might wonder whether they actually work or whether they're effective. So clinical decision support systems for AMS programs can assist in optimizing prescribing and reduce resistance and consumption of antibiotics, particularly the broad spectrum ones. And clinical decision support systems increase compliance with recommendations, particularly for empiric antimicrobial therapy, and reduce overall healthcare costs. The Bond paper here is a study from 2017 by the Southeast Sydney and Illawarra Shoalhaven AMS group, where they combined use of a clinical decision support system with collaborative ID service governed by their antimicrobial advisory group. So they were able to demonstrate reductions in fluoroquinolone use, gram-negative resistance, and reduced length of stay, and since then they've upgraded to the new guidance program. The systematic review mentioned here by Trotter et al. Reported 13 publications that showed mortality benefits and cost reduction. And it was also nice to see guidance featuring in that systematic review as well. So what makes a good clinical decision support system? Well, we particularly take a user-centered approach. So it needs to be easy to use. It needs to fit well into prescriber workflow, including an EMR prescribing workflow if there is one. There shouldn't be too many clicks to get to the answer or information, which should be based on content that is up to date and relevant for the user. A systematic review by Davey et al., so that was in 2017, recommended that a clinical decision support system for AMS should provide advice or feedback, and also be used in combination with other AMS tools, such as approvals and audited feedback. So combining all of this, there can be a whole of system approach to AMS. A good CDSS should have features that meet hospital accreditation standards and also clinical care standards for AMS, and also perform well and meet the standards for regulations, standards and regulations for software development. So those at the moment in Australia are the Therapeutic Goods Administration, ISO standards and IEC standards. So this is an example of our clinical decision support system that we work with. It's a knowledge-based system, and it supports clinicians by taking them through a decision support pathway that leads to an assessment of whether what they intended to prescribe was appropriate. And if not, it would provide a recommendation that was more suitable in line with the organisation's preferences. So there are references to national guidelines or hospital guidelines, whichever is relevant at the time. Supporting that decision support algorithm that you just saw is a content management platform that allows clinicians to update guidelines without having to rely on IT services, because we know that's not always available. And this allows changes in practice recommendations or drug shortages to be dealt with in a timely manner, and earlier dissemination for changes in clinical guidelines. This is an example of what we call the Universal Indications List, and this was an earlier piece of work that was a tool to have a list that is standardised for terminology and is important for things like dashboard reporting. And it's also mapped to international SNOMED codes, which enables us to connect and transfer unified data across platforms such as EMRs, business intelligence systems and other systems. And the other reason why the standardization is important is so that we can use it for dashboard reporting, which are automated and interactive. And the goal is to cut down on reporting time and stratify data and be able to support AMS teams to spend more time making interventions and providing feedback to treating units. So a big part of uptake for a clinical decision support system and many other IT programs is how well it is implemented. It's important for a system to be easy to access and incorporated into local clinician workflows. And there should be adequate training around the system and for it to perform well enough to be able to influence decision making. There needs to be strong governance around AMS and support for the use of the program. There's continuous quality improvement, so that should be included and factored in, as well as ongoing evaluation, and adequate attention for an IT and clinical resources should be allocated to ensure the system remains up to date and functioning well. An example implementation is a Southeast Sydney and Illawarra Shoalhaven group. The group shares or has a hub and spoke model, which is collaborative, and they share a large EMR and the clinical decision support system. And from a clinical point of view, their hub and spoke model allows them to share content management, ID services, improve collaboration and research in the network, and make use of updates and use of technology. So this structure and infrastructure supports virtual care and telehealth models, and they run regular AMS rounds remotely using the data from the systems that I've just mentioned. So interoperability is something that is a challenge in hospital systems with multiple systems that can be complex. So the HL7 standards help with data transfer and system operability. So these standards have changed significantly over the years, and systems are moving towards better transfer of information between systems through FHIR, so that's fast healthcare interoperability resources. And there are good examples around the world and in Australia where systems have enabled two-way integration into EMRs, which is a challenging thing that we're trying to address. So, of course, if we're talking about modernising AMS, the question about AI arises, and there's been an explosion of research in AI in medicine in recent times, but very few models have actually been implemented successfully. And AI has the potential to revolutionise clinical decision support systems and healthcare. So then the question is, can we create an AI model that provides clinical decision support and just let it answer all our clinical questions? So there are, and the answer is probably, potentially, but there are lots of things to consider. The governance and ethics around AI is being established. So, we're looking at this in the early stages. We've got, where are you going to get your data from? the answers in AI models that AI models provide aren't always the most relevant or up-to-date ones. So if an AI model has been trained on old data, that's what it will provide. How do we know how reliable the information is? AI models have been known to hallucinate, especially when information is missing. And so measures on AI output around predictability and reliability widely range between being spot on to being completely incorrect. And that's just not good enough yet for a system providing clinical decision support. There are also other issues like AI drift and bias and cost to consider. So if anyone's interested in developing AI tools, and particularly for decision support, this is an AI lifecycle, which is an example of what needs to be considered when developing a product that uses AI. So the future of AMS in the digital space is really interesting, and there is lots of opportunity for us to explore further. I think it will still remain user-focused, and we're going to see lots of more automation. So for us, it's automated reports or automated prescription assessments, and we're certainly going to look at opportunities to incorporate AI in software development, as well as incorporating it within our everyday practice. The aim is to improve the reach of ID and AMS services through technology and set up structures that increase collaboration and communication, such as telehealth or network models. Certainly improving interoperability or data connections between systems, such as clinical decision support systems and EMRs, will improve efficiency and communication. And for paper-based hospital, digital transformation and supporting hospitals on their journey, is something that we still need to work on. So yeah, at the end of the day, I think it's important to continue to consider our users foremost and meet prescribers where they're at. Include them when considering digital tools for their work, and consider advancements. So, with further advancements in technology, our users, prescribers, AMS teams remain the centre of what we call our learning health community, and we continue to collaborate with them. So thank you.
Thank you so much, Ngan-Ha. That was a really great overview and example of one of the digital tools that we use and I use every day here at Royal Melbourne as well. I'm going to open it up for any questions from the group. I'm sure Ngan-Ha will be more than happy to answer. We have certainly enough time if anyone has any questions.
It's not a question, but it's a comment. So people use the term AI fairly loosely these days, and I think it's important to recognise that there are different sorts of AI. So some of the work that we are doing is specifically looking at tools like natural language processing and machine learning, which are not generative AI, and we are training that data with human experts, and validating those algorithms, and all the way through, I guess, we hear about the large language models and generative AI, which is where we still see a significant risk. But there's also, I think, an opportunity for us to think about piecemealing up activities that can support stewards. And you might have heard the term agentic AI, where individual tasks can be assisted along a patient journey, and that is something which I think we're starting to see a little bit more of. So I think for antimicrobial stewards, the biggest issue is how do we make sure that everybody's trained in how to work in our organisations with AI opportunities, and what are the sort of people that you need around you. We've got Daniel Capurro talking next, who is a clinician informaticist, which I'm very happy about. but actually many of us do need to be upskilled so that you're going into this with eyes wide open. And you will hear next year about one of the projects that Jenna's actually been working on, where we've been spending, over 12 months extracting detailed data out of Epic, so that we can think about supporting automation of audit and feedback and appropriateness, which is obviously one way to reduce the auditing burden on AMS. And Jenna, you'll be talking to us about that next year, I'm sure. But it's this is very takes a lot of time, a lot of effort, big teams, and the return on investment is still not clear for some of these activities. So that's my throwaway comment. But Ngan-Ha, it's lovely to have that summary of the considerations that we need to think about. We've been on a journey since 2005, really. So nearly 20 years of working in the digital AMS space, and it's a difficult space at the moment, but obviously great opportunities.
Yeah, thanks, Kaz. I think you summed that up pretty well. And yes, I'm definitely hoping to present some of the work that I've been working on for over a year now. It's definitely challenging, and I've learned a lot about the data and the way it's captured in EMRs, and even, working out the indication for the antimicrobial is very challenging. So yes, I can definitely speak to that in one of our seminars next year.
There is a question about interoperability. Ngan-Ha, did you want to answer that, or did you want me to answer that?
Yes, so interoperability is a big challenge. What would your suggestion on fixing this be? So thank you, Kamal, for asking this. Yes, I agree. I think there are many approaches to interoperability. Standardization of terminology and common data points help with data transfer and acceptance. And in terms of systems, there needs to be a recognition from both systems when you're looking at it, that there is the goal to minimize duplication and really address some of those challenges. I think technologically we can do it. So, for example, there are web APIs that allow or enable integration between systems. There are methods such as CDS hooks, so where we can send information in the form of cards back to a particular EMR, and we've worked out a way to do this. So and it's been demonstrated in some of the literature as well. So I think it's about having the questions with the IT services and IT governance in each hospital.
And I'd follow up by saying the single biggest barrier to interoperability is not the technology, because there's always a solution. It's actually the business rules of the organisation, the EMR, to allow you to do it and for them to recognise the importance. And obviously within EMRs, they also have tools that support, for example, implementation of machine learning algorithms. But Daniel's got his hands up, so
yeah, I just wanted
the wealth of experience.
I wanted to add, I agree that I think at this stage, technology is not the problem. We have standard terminologies. We have, interoperability standards. But I would say, so democracy doesn't really work in informatics. And if we let people figure out their own standards, and they say that standards are like toothbrushes. Everybody thinks that theirs is the best, but nobody wants to use nobody else's. FHIR was created here in Australia, actually, by someone in Melbourne, but the major adoption came from the US when they mandated by law the use of FHIR as the standard APIs to expose data, to enable access to patient data, and that sort of tipped the balance, and then everybody started adopting this, and the major vendors and tech companies starting adopting it. So then the business case came very, very clear when the right incentives were rolled out. So I think that's what we're missing here. And the other bit is that there's always been this sort of analysis paralysis in terms of like it's hard to pick one standard because there are many standards that can do the same thing. And then the question is, everybody sort of paralyzes when they need to pick one. And I think that ends up being more problematic. There's no perfect standard. You can do your assessment and try to pick the one that seems the best, and stick with it. Otherwise, you're just going to wait for the next best thing, and you're just going to waste another 10 years waiting for that.
Thanks, Daniel.
Daniel, would you like to answer Ted Clue's question? How do you see the exploration of AI opportunities as a future intervention AMS, despite the fact that practice of AI is very poor in developing countries?
I think so. It's probably two things. I think AI, we're seeing the capacity and capabilities just explode over the last 2-3 years, and that is probably going to make it even now. It's you don't even need deep technical, ability to create reasonably working code. I think it's doing two things: is democratizing access. So I think maybe even in developing countries, we will be able to. It's almost like what happened with mobile phones. When we thought about digital technologies for healthcare, it was all centered around EMRs, and we said, oh, developing countries don't have this widespread access to EMRs, and we're creating a digital divide, which is true. But then we saw the explosion of smartphones and mobile devices, and that was sort of the leapfrog towards digital access for the broad, population. And a lot of developing countries have been heavily investing on digital strategies that involve mobile devices. I think we're going to see something similar with AI, in which the availability of these very powerful technologies that you can access via the web, via prompting, that might, democratize access. On the other hand, it adds, when anybody can access, then it presents additional challenges around, what Ngan-Ha described, governance and safety and, hallucinations and so on. It's a very, very fluid environment at the moment. But I don't think it's going to be like one monolithic approach to, this is your EMR, this is your large language model, this is how they talk to each other. We're going to see a multiplicity of sort of architectures, and we need to see how, where they lead us. It's going to be changing by the week, I think.
Thank you, Daniel. We might actually move on. I don't think there's any more questions in the chat, so we'll move on to your presentation. But before I do that, I firstly want to congratulate you, Daniel, on behalf of the NCAS team to your appointment as full professor at the University of Melbourne School of Computing and Information Systems. That's just such a massive achievement. So congratulations from all of us here. So Professor Daniel Capurro is a clinician, informatician advancing digital health innovation. He develops methods to analyse care pathways and test new technology safely, combining clinical expertise with informatics and AI to improve health system performance and patient outcomes. So I hand over to you, Daniel.
Thank you so much for that very, very kind introduction. And so we're going to talk a little bit about why inference matters for AMS, and that's going to speak a little bit. It's a good segue from what Ngan-Ha just described and what you were describing, Jenna, about the data. So when we think about what would an ideal digitally enabled AMS program entail? And this is probably an invitation to everyone here. In the informatics community, there's a series of papers that have been published over the years they're called desiderata for ... desiderata for decision support, desiderata for, all different sort of core informatics principles. I think we could benefit from a paper describing what would an ideal digitally enabled AMS program look like in the age of, digital technologies that we're experiencing right now. But I was thinking about what would that look like, and this is just a bullet list of things that I think might be necessary there, and it will be, perfect data collection, guideline assisted prescribing, not just when we're assessing appropriateness, but also at the time that I'm prescribing. Then we could, double click on how do those guidelines get, documented, represented in a computer readable format, and then executed at prescribing time. Automated appropriateness assessment, restricted antimicrobial approval system, support for susceptibility matching. This is, if I get a culture with a certain agent, and then, how does that get automatically matched to the antimicrobial that the patient is receiving, and, recommendations for switching, de-escalation, oral switch, automated reporting, and probably some more. We can get very, very creative in ways to use technology. And when we think about just this first element, guideline-assisted prescribing, when we think about what is a clinical guideline, and a clinical guideline is just a collection of PICO questions and statements, okay? And I'm gonna go through what do we mean by PICO questions or statements, because last week I was doing round at the hospital with my team, and the intern, the resident, and the registrar, they had never thought or heard about this concept of a PICO question, and I almost quit my ward round. And so what is a PICO question? Is a way to organize our thinking that helps us think about research, but also about clinical interventions. And the P is for patient and the population. The I would be the intervention, the C is the comparison, and O is the outcome. And that's, if you take any clinical guideline, it's usually a collection of these different things. One example for this PICO question would be adults with gram-negative bacteremia. The intervention would be 7 days of antimicrobials. The comparison would be 14 days of antimicrobials, and the O would be mortality. And down here, there's the systematic review that did exactly that. And then that can be turned into a recommendation in a clinical guidelines. Another example, and this is something that we've been doing for our antimicrobial appropriateness, if you're trying to help someone or support someone at prescription time for an acute cystitis, there's a bunch of things that you need to know about the patient, okay? In this, P component, to understand what is the recommendation, what is the recommended treatment. You need to know whether the patient is female or not. You need to know whether the patient is an adult, whether the patient is pregnant or not, whether they have a normal urinary anatomy, whether there's normal kidney function or not. And all these different things, we tend to think that they're easily accessible from the EMR, but as Jenna will probably tell you in future seminars, it's not that easy, especially things like pregnancy, for example. And why is it hard to automatically derive? Because if I let the clinician select, for example, oh, what's the indication? It's, acute cystitis in a female non-pregnant patient, then a lot of the work is something that the clinician actually did, pick the indication for the antimicrobial, and then the the chain after that gets a little bit easier. But automatically defining that the patient has acute cystitis and is not pregnant and has a normal urinary anatomy, that's a bigger challenge. And why is that? Because in the EMR we have usually multiple ways of representing the same concept. Okay, and an EMR is usually a combination of raw data and abstractions on that raw data. And as an example, I'm going to take a simple example like community-acquired pneumonia. And I can, as a clinician, I can say that the patient has community-acquired pneumonia, and I can document that in multiple ways. I can, let's say if I'm an Epic user, I can document it in my clinical note. I could document it as the main problem in the problem list, and that gets an ICD code and it gets a SNOMED CT code. But you could also document it in the discharge summary. You could also document it in after the patient has left, when the patient's chart is being coded, and that can be sort of appropriately coded by experts. So again, even this high-level concept of community-acquired pneumonia can be documented in multiple different ways. But as a clinician, what I'm doing, this idea of a community-acquired pneumonia is an abstraction of lower-level concepts. If I come in the, and I'm seeing in the emergency department a patient that has, let's say, 4 days of cough, of dyspnea, of fever, has an elevated CRP, and somebody did a chest X-ray, and I'm looking at the radiology report that shows consolidation in the right lung, then I can quickly say, yes, this patient has most likely a community-acquired pneumonia. It may not be the only option, but it's probably the most the largest probability in my differential. But again, fever is an abstraction in and of itself of other concepts. So again, fever, you can also document it in a structured way with ICD codes or SNOMED CT codes in free text, but also fever is an abstraction of multiple body temperature readings. Okay, and we can be even more extreme in terms of this idea of multiple levels of abstraction when we look at the radiology report. A radiology report is only an interpretation of what the radiology is looking at in an image. Okay, image of that chest X-ray. And an image is also a representation, is a 2D representation of a bunch of pixels, which are, each pixel is a collection, is a 3 numbers. Okay, and so you can see that when we're starting to think about automating this, what data elements are we going to use to represent this idea of a community-acquired pneumonia? Am I going to look at the text contained in the patient's record saying that they have a community-acquired pneumonia? Am I going to look at the individual data elements that are building this community-acquired pneumonia concept? Am I going to trust this idea, the mention of fever, or I'm going to look at measurements of body temperatures? And we could say, body temperature is easy. The quality of that data is pretty high, so I'm going to rely on that. But then I start facing issues like, did the patient have fever before showing up to the hospital? Where's that data being collected? Did the patient feel a subjective sensation of fever, or do I already have an actual measurement of elevated body temperature, and so on? When we have algorithms that can analyze data at the pixel level, am I going to trust that assessment? Am I going to analyze the image? Am I going to do NLP on the radiology report, or am I going to do NLP on the clinician note making the diagnosis of community-acquired pneumonia? So you can see that you can go through deep rabbit holes very, very, very quickly. And an example of, I would say, basic in health informatics research is something that we did a few years ago when we looked at all the different data elements that can represent what we call a digital phenotype, and we model them from a temporal point of view. And we said, there's different kinds of intervals that you can use to abstract a higher level concept. For example, in this case, these 3 instants of elevated body temperature make this instant of a fever, okay, or this interval of a temporal interval in which a patient had a fever. And so we call these instant-based intervals, where the patient in this case was hypothermic, okay, less than 35 degrees. But there's another kind of interval. For example, a hospital admission is not made out of tiny instants of being admitted into the hospital. It has an start interval and an end interval, which in this case is the admission and the discharge. And those are what we call the bounded intervals. And you have another kind of interval, which is this moving window interval. If you're trying to diagnose, let's say, acute kidney failure, you need urinary output, hourly urinary output in this 6-hour window. So you build this abstraction, which is a 6-hour window, and you check the data, make sure that it meets the concept, and then you say, yes, it's true for this particular 6-hour window, and then I move 1 frame to the right. And then you can start doing interesting things like temporal relationships. And there's some, very smart person in the 1980s was building expert systems unrelated to healthcare, and they created this this temporal logic that allows you to compare intervals in terms of their temporal relationships, like this before and after, the overlap, the equal, the during, and their 13 distinct temporal relationships. And then we can think about all the different patterns: an instant before an interval before an interval, and so on. And this is what we call digital phenotyping. When we think about digital phenotyping, even if you're using, there's the big, push now to use large language models to skip sort of this hard coding all these different rules. But when you think about prompting a large language model, you will need to prompt these same temporal relationships. If you want to find patients with fever, you're going to have to think about, what am I looking for? Am I going to ask the large language model to look at the body temperatures? Am I going to ask the patient, the large language model to look at the mention of fever or the negation of fever? Or am I going to, go higher in this sort of hierarchy of concepts? So these fundamental ideas are persistent even when we're thinking about AI and generative AI. And how do I address all these different things? Because as Jenna was describing, the data is not perfect. And so usually the push, or frequently the push, is to sort of impose or incentivize structured documentation. And the problem there is that structured documentation takes more time, and usually there's a cost of richness in the description of the language or the clinical concepts. Natural language allows us way richer descriptions of what's going on. What do we do with missing data? If the patient is missing, as I described, the body temperature measurements before the patient was admitted to the hospital, what do we do? And then inconsistencies. If I have a note that says that the patient does have a community-acquired pneumonia, and then later that same day, I have another note by the intern that says that the patient does not have community-acquired pneumonia, how do I reconcile those inconsistencies? And again, even if I'm using large language models, even if I'm prompting a generative AI system to make those assessments, I will need to have a clear logic on how to resolve those inconsistencies. And that comes from clinical inference. And even at this stage, even if we we let these models, do their thing behind the scenes, there needs to be tight control and prompting and boundaries around their reasoning. So it needs to be a balanced approach. Right now, again, many years ago, we did a study comparing 3 different hospitals, trying to understand how many of all the structured data elements necessary to build all their surgical quality metrics were available in each one of those 3 hospitals. And the range was very, very, very broad, even when they had the same EMR. This was looking at 3 Cerner hospitals in Seattle. And one hospital could only capture 14% of their data elements in a structured format. On the other end of the spectrum, we found another hospital that was able to collect 85% of all their data elements necessary to calculate their surgical quality metrics in a structured format. So again, it's not a matter of the technology. In this case, the 3 hospitals were using the same piece of technology. It was all around were the strategic decisions made at the time that these EMRs were designed and implemented and rolled out. There's a choice there that needs to be made. There's a choice in terms of what data elements do we actually care about, what data elements align with our clinical strategy and our clinical governance, that we will mandate the structured documentation. And the other interesting thing, and that talks about prompts. When we looked at the data elements that were not being captured in structured format, about 1/3 of them were pieces of information that we could probably ask the patient or their medical treatment decision makers. And it's not something that we need to overburden, clinicians in terms of documentation. So there's a big space to incorporate patients and their families in providing us the necessary data for, to inform these decision support systems that we all want in place. Because again, as Ngan-Ha described, they decrease mortality, they improve quality of care, but we need to have the right data there. And we've been advocating for years to have a learning health system approach, where most of what we think about is the data to knowledge component here on the right, taking data and generating knowledge, and then knowledge and to practice. But there's this third bit, the practice to data needs to be also strategically designed. If, as an organization, we have strategic goals in terms of quality and antimicrobial stewardship, then that needs to be part of the discussion on how we design documentation from the beginning. EMRs are not static. EMRs are constantly evolving, and we need trained clinicians to be able to understand how documentation works. How can we change documentation? In the case of the Parkville Precinct, for example, which we are Epic users, we need to have clinician builders that understand deep inside how the EMR works and can be useful resources to modify the way that we capture data to make it more user-friendly and more aligned with our long-term strategy of this learning health system cycle, which includes, smart AMS. So again, just as final messages, EMRs can store the same clinical concept in many, many different ways, and even simple components need clinical inference. A balanced and strategic approach to documentation is key, and that needs to have the right clinicians with the right training in clinical informatics and with deep knowledge of how their EMR is dealing with this documentation. Generative AI will have deep influence into what happens. We're seeing now ambient AI scribes. They're going to change the way that we document clinical encounters. Is there an opportunity to improve structured data capture at that time? Also with data extraction and knowledge generating. But again, even when we think about generative AI for documentation and data extraction, it's not going to work automatically behind the scenes. We need to be able to tell these systems via prompts what is the underlying logic that describes our understanding of concepts like a community-acquired pneumonia, an uncomplicated cystitis, a hospital-acquired pneumonia, and so on. And with that, I finished my presentation. Thank you so much.
It was amazing. Thank you, Daniel. I've definitely found myself down a many rabbit holes with looking at the EMR data from our hospital. And it's very challenging. And yeah, the data is captured everywhere in the EMR. I find myself jumping from, the medication record to the progress notes to results, like all over the EMR. And I have to pull in all of this data from different points and try and get that in a structured way to even think about automating any assessments of antimicrobial prescribing. So that was a really great overview. I'll open it up first to anybody who has any questions for Daniel. Kaz.
It's more for the audience who are online today. So thank you for joining. You'll see that there's very little work that we do that doesn't have some digital overlay now. So all of us, obviously been knee deep in it for a long time myself, but for our audience, where do they learn? You know, where are the places where they can learn some of what you're talking about? I will promote the Learning Health Systems short course at the University of Melbourne. The Centre for Digital Transformation of Health does at University of Melbourne, which a lot of my staff have done, and that gives you a good introduction into that learning health cycle. But I'm going to ask you, Daniel, because I think we don't get taught this. We don't get taught any of this in medical school. You know, the curricula is not fit for purpose in terms of digital health at the moment. And yet we get there's a tsunami of stuff coming into our inboxes, LinkedIn feeds every single day around AI. How do we keep up to date with this?
That's a tough question because it's tough for everyone. I think these days doesn't matter at what level you are, you still get flooded by new stuff going on. I have a gazillion bookmarks of stuff that I want to read and videos that I want to watch and talks that I want to go to. I think probably the easiest way I would say is a combination of if you're working at a health service and your health service has an EMR, it probably has existing training modules on how to use your EMR in better ways and how to change the documentation. Again, here in the Parkville precinct, we have the clinician builder programs. Epic has crazy hours. It's not very friendly to sign up for those, but I would highly encourage that if somebody wants to start doing a little bit more in this area of clinical informatics, understanding how your EMR works, I would say would be the starting point. After that, I think it depends on how deep you want to go. I think that the Learning Health System short course is a good overview of how we can take this data into actionable insights and feeding them back into clinical practice. I'm completely biased because I was part of creating that short course, but I think it's a good overview. It gives you a hands-on. You can see the data doing things, and then the third aspect, I would say, right now, I don't know. There's many different options, but there's a few resources that have been put together by clinicians on how to use AI. There's one that I really like. I don't have the link right now, but it gives you like an overview of the different sort of components of deploying AI for all the different clinical activities. I can share that with Jenna, and then maybe Jenna, you can share it with everyone else that's attending here. And maybe the last thing is in your professional social media. I know social media is, it's both, again, another rabbit hole that we don't want to spend too many hours in, but there's a few key individuals that are doing things at the cutting edge. My favorite person in this space is the Chief AI Officer at UC San Diego, and that's Karandeep Singh. I think that that's currently my favorite person in terms of who's doing the cutting edge work internationally. And I think that's probably where things are happening right now. Cass, you're on.
Oh, sorry, I just realised the Centre for Digital Transformation of Health holds regular webinars with some of these people. I don't know if Karandeep has talked, but Nigam Shah is the other one I really like.
Yes.
And the reason why I like him is he's from Stanford, isn't he?
Yep.
He provides an extremely balanced view about where your effort should lie. And the one thing I have taken away with all the digital phenotyping and other AI research that I'm doing right now is that the most important thing before you step into this space is to make sure you have the use case right. If you don't understand the use case, no matter what you do, it's not going to work. And so our philosophy, we have a new Centre for Research Excellence funded. We've called it Radar, and it really is focusing on digital AMS. And Daniel's obviously part of it, while he's talking today, and is because we are now bringing in human factors experts and implementation scientists to wrap around the interventions to make sure that those workflows, future workflows are fit for purpose. And I think that's actually really, really important. Even for non-AI, for any AMS, that use case of why you do what you need to do, why we do what we do needs to have a very strong use case. And obviously it's matured over the years in Australia. And I had the fortune to be on sabbatical this year, and I had spent time in Europe, Italy, Austria, and a few centres in the US. And you'd be amazed, possibly shocked to know that our AMS is practices anyway on the ground are far more sophisticated than what I saw in the US and in Europe. So we are coming from almost from a different level today when we're starting to talk about introducing AI as well.
I think we've definitely found that as well, like taking EMRs that have been built and from the US and then trying to make them applicable for our AMS setting here in Australia has also been quite challenging, and they work very differently to us. So we've had to make lots of workarounds to try and get these EMRs to suit an Australian setting.
Good point, Jenna. Yeah,
sorry.
you finish and then I'll wish everyone.
Yeah. That we'll probably have to leave it there because it's almost 9:30. Thank you everyone for joining today's session. Just a reminder that the recording will be available on the website after today's session. This is our last session for 2025. And next, I've just put up the seminar series calendar for next year. So we're going to take a break in January, and then we will be back on the 18th of February with our first topic of animal health. So until then, I hope everyone has a lovely Christmas and Happy New Year. And then we'll see you all back again in 2026.
Thank you, Jenna. Amazing, wonderful session today from everyone at NCAS. Have a wonderful Christmas and you'll hear from us soon.
Bye.
Thank you.
Bye, everyone.